prestigious conference. And of course, thank you so much for Saja Pharmaceutical for their support. Actually, I'll go just a review. This is my disclosure. On the LUTS and the BBH, most of the LUTS are common and they have multifactorial etiology. However, 48% of the cases are due to BBH or enlarged prostate. BBH is the fourth common disease diagnosed in USA above the age of 50. It's a progressive disease, and the incidence and the prevalence are increasing with age. And if left untreated, the patient is living with his symptoms in a bother, which can interfere with the daily activities, sexual dysfunction, physical and mental health, and even the relationship with his partner. And he is afraid of tomorrow being a progressive disease that can end up in need of surgery or acute retention of urine. So whenever you have a patient for the first time, you have to assess how risky the patient for clinical progression of the prostate. Number one, the higher the age of the patient, the higher the progression rate. Men with LUTS, moderate to severe LUTS severity, have symptoms are 3 times more likely to have acute retention of urine than the mild symptoms. Again, men with reduced urine flow have 4 times the risk of acute retention than those with higher urine flow. Prostate volume above the 30 gram are at progressive risk of retention or need of surgery, and the PSA of more than 1.6 is associated with very progressive rate. However, PSA and the prostate volume in most of the studies, as you see here, is associated with high incidence of acute retention of urine. So once you have your patient at the first time and you have these markers in hand, an age above 50, PSA of 1.5 or more, enlarged prostate of 30 gram or more, IPSA score more than 8, and low flow rate, then this will be translated into progression in terms of worsening of symptoms, deterioration of the urine flow, retention of urine, or need of surgery. Having said that the BBH is a progressive disease, the traditional way of treating those patients is to alleviate bothersome symptoms. However, more recently, the focus is on the alteration of disease progression and the prevention of complication. However, there is a gap between the BBH patients' concern and what the physicians are thinking. So most of the patients are worried about the long-term risk, but the physician do not believe in this. So very low rate of physicians are concerned with the long-term. So our current practice is driven by symptom treatment. Look at this one from France. 48% of BBH patients are treated with alpha blocker monotherapy. The picture is no different in Italy, where 64%, USA and Canada are nearly the same. Why monotherapy with alpha blocker dominate in BBH medical treatment can be for the reason of rapid symptom relief, efficacy and safety may be some patient preference. However, in the market, as you know, we have a cocktail of medication that can be used for treatment of BBH. Let us go through the guidelines, and this algorithm is extracted according to the last guidelines published by the EAU. Number one, if you have a patient with if you have a patient with LUTS without indication of surgery, number one, you have to assess if he has bothersome symptoms. If no, then watchful waiting, education, and lifestyle changes only. If he has bothersome symptoms, then you have to assess if he has nocturnal polyuria, which is the most bothersome symptom in a BBH patient. If yes, then we'll go for vasopressin therapy. If not, then we'll assess if he has storage predominant symptoms. And if yes, then we'll go for antimuscarinics. If no, Then we'll go for assessment of prostate volume. If less than 40 gram, then education, alpha blocker, with or without alpha blocker. And if there is some residual symptoms, then we'll add antimuscarinic therapy as well. If the prostate size is more than 40 gram, then we'll assess if the patient is for longer-term therapy or not. If not, then we'll go for the same track here. If yes, then we'll go for lifestyle changes with or without alpha blocker combination with alpha reductase inhibitor or PDE5 inhibitors. And this is the combination therapy. When it comes to alpha blockers, this is all the alpha blockers available in the market. And as you see, we have alpha 1A, which is our targeted in urology, where it exists in the prostate, bladder, neck, vas deferens, and seminal vesicles. B in the blood vessel, D in the bladder and spinal cord. So the affinity of the alpha blocker to these will determine whether this, how the tolerability and the side effect will be. For example, tamsulosin has an equal affinity to alpha 1A and D rather than B. That's why the cardiovascular side effects are less, because it's not working on the blood vessels. And there is 2 molecules of tamsulosin, modified release and the OCAS. And why it comes to OCAS, there is some points to highlight here. As you know, the therapeutic goal of treating BPH patient is to improving voiding and improve storage symptoms over 24 hours in a very compliant, easy way with low cardiovascular effect. So the limitation of the current alpha blocker now is drug release is usually depending on the availability of water, is not covering 24 hours, and should be taken after food. So we need a molecule which can fulfill the following criteria: independent of food intake, improve cardiovascular safety and tolerability, and of course covering 24 hours. And this is the OmniCocaz. OmniCocaz is very selective with lack of interference or interaction with our other medications, and has a side effect which is nearly comparable to placebo. Furthermore, it's working on both the static and dynamic component of the bladder, being working in alpha 1A, so it will relieve the bladder outlet obstruction and improve obstructive symptoms, and working on D, so it will increase the bladder adaptation and relieve the irritative symptoms. What is OCAS technology? It's a very OCAS standing for oral controlled absorption system. So the tablet is covered with a gel layer which carries water throughout the entire gastrointestinal tract, even to the colon where water content is very low. That's why sustained release over time and 24 hours, unlike the other ones, are working only in the upper gastrointestinal tract. That is the first published paper about OCAS by Christopher Schoppel in 2005. And this is the conclusion of that paper: continuous and consistent 24-hour plasma concentration offers a lower Cmax with less side effect and independent of food intake. Here, of course, it's a unique formula leading to sustained blood concentrate over time if compared with the MR, which has a peak of plasma concentrate going rapidly down. Again, it's optimal control, working day and night for better control across the 24 hours. And again, is independent of food intake, and this is the plasma concentrate before and after taking food. When it comes to cardiovascular safety issue, there is a comparative study between OCAS and the normal formula or the modified release, which is called orthostatic study, comparing the 2 molecules, giving for 2 days, wash out for 1 week, and then compare again. The primary efficacy variables were the result of orthostatic stress test performed before 3 minutes before giving the tablet, 4, 6, and 8 hours after the dosing, and we will see the change in the blood pressure and pulse rate when the patient is lying down and then sitting up and stood or standing after this. And this is a comparative study between OmniCocaz and the conventional one. Only few subjects with OmniCocaz has a positive stress test for orthostatic, and usually the difference started at after 4 hours. Only for 17% with OmniCocaz compared to 31.7 are positive for the test. So OmniCocaz has less inhibitory effect on blood pressure and pulse rate, has superior cardiovascular tolerability, and minimal effect on blood pressure. Again, combining OCAS with other molecules like alpha-zosyn, for example, with the same orthostatic study, you see here the difference. Nearly 87% of patients who are taking alpha-zosyn are positive for the test compared to 14.3, and the difference is higher 6 hours and after. That is the answer why OmniCOCAS. Novel technology with high selective receptor affinity, covering 24-hour, high compliance, taking any time of the day, high efficacy, no pharmacological interaction with the others, and no food interaction. So alpha blockers, all alpha blockers are reducing the IPSS score, improving the Qmax, having the same efficacy more or less in improving all the symptoms, and are not dependent on the size of the prostate or age of the patient. However, alpha blockers do not reduce the cumulative incidence of acute renal retention or the need of surgery compared to placebo care. Again, there is a high risk of patients are needing retreatment after alpha blocker monotherapy. So the retreatment rate after alpha blocker monotherapy is higher among patients with high risk, what we told before, especially with those with the prostate size above 40 grams. Side effects are nearly the same, but there is some molecules which are having higher side effects, like retrograde ejaculation and self-zine compared to tamsulosin, for example. Patient preference for treatment is based on the symptom relief or not. You'll be astonished here after the probe study that 75% of patients prefer a drug which could decrease the risk of surgery by 50% versus a drug which will give faster relief. And this is the slide, as you remember, the discrepancy between what the patients are thinking and the doctors are thinking. Now, what can we do right from the start for PDH patients with moderate symptoms to avoid progression and ending up with complications? Of course, combination therapy. 5 alpha reductase inhibitors plus alpha blockers. Alpha reductase inhibitors have a slow rate, recommended for long use. Of course, it's working by converting the testosterone to dihydrotestosterone. Are tolerable, recommended to be given for patients with moderate severe LUTS and enlarged prostate to avoid progression of the disease. Combat study, which is combination therapy. This is the study design, 3 arms, tamsulosin alone, lutastride, and the combination therapy, follow up to 4 years here. Combination therapy is associated with more improvement in the total IPSS score compared to the other monotherapy. Voiding symptoms are better compared to the other monotherapies. Again, storage symptoms sustained up to 4 years is better with the combination therapy. Qmax is higher in combination therapy compared to alpha blocker or lutastride alone. Now, the risk reduction of acute urinary retention is very low in a combination therapy compared to the other monotherapies. And of course, improving the quality of life and the Q8 in the IPSS score. If you ask the patient if you were to spend the rest of your life with the urinary conditions, just the way it is now, most of them agreed on combination therapy versus the monotherapy. So again, once you have the high risk criteria, please start combination therapy from day 1. Now, alpha blockers are short acting or rapidly acting, and alpha blockers are long acting medication. Conduct a study which is determining when to start. Shall we start from day 1 or to do whatever we do in our daily practice right now? We'll start alpha blockers, and if there is worsening of symptoms, we'll add 5 alpha reductase inhibitor. Now conduct studies comparing 2 arms. One arm with fixed dose combination therapy from day 1 when you have high risk patients versus watchful waiting and then with initiation of tamsulosin when symptoms are not improving. Primary endpoint is a change in the IPSS score over 24 months, and the secondary endpoint will be change in the BPH impact index, question 8 IPSS score, and of course time to progression of this one. Here, more than half of our patients are in the watchful waiting with initiation of tamsulosin only, they need to escalate into tamsulosin within the first 6 months. This means only going for tamsulosin again or watchful waiting is not successful. And you have to start within 6 months. If you don't start from day one, so the latest for the benefit of the patient is 6 months. Again, IBS score is improving higher in the fixed dose combination therapy compared to the watchful waiting or step-up therapy. Not only this one, having the combination therapy from day one will change the score from moderate to mild in 24 hours and starting as early as 9 months. Again, changes in the IBS score with the fixed combination therapy is better and started as early as the first month, sustained over the period of 24 months. So immediate intervention with combination therapy provide rapid symptom improvement as early as month 1, superior symptom improvement at each baseline with a high statistical significant difference, sustained superiority in symptom improvement over 2 years of treatment versus watchful waiting of initiation of therapy. Again, the combination therapy will decrease the risk of progression into acute renal retention and by 43% as relative risk and 11% as absolute risk. Again, health outcome in terms of the quality of life is improving in patients with combination therapy from the start compared to the step-up therapy. Of course, fixed dose combination therapy against the arm with tamsulosin alone have some side effects, as here. Most of our protocols and guidelines recommended the first-line treatment of BPH at risk of progression with alpha blocker and alpha reductase inhibitors. The second combination that can be is tamsulosin plus anticholinergics. And this is the anticholinergics. I think the colleague before me elaborated very well, but we have non-M3 selective and M3 selective. And all what do we need from the antimuscarinic here is high efficacy and long-term efficacy, no interference with normal voiding because we're treating BPH patients, tolerability and safety, and no drug-drug interaction. To have this one, you have to have a balance between efficacy and tolerability. And this, of course, will depend on the pharmacokinetics, pharmacodynamics of the molecule, and selectivity to the M receptors. One crucial question: are all antimuscarinic the same? The answer in a meta-analysis review, yes, all are effective, but they are different in tolerability, safety profile, and with clinical significance. Most of the anticholinergic has all the side effects, and most common is blurred vision, sleepiness, constipation, and dry mouth. In BPH patient, the incidence of retention among patients who are receiving antimuscarinic is only 1.1%. And this is the highest complication that happen with patients with antimuscarinic is dry mouth. And that is the makes the persistence on taking antibiotic is very low. Most of the patients drop off the medication. Here, for example, on top of the list is sulfonylurea. Patients are taking for the highest on the list compared to the other up to 12 months. Why? Because most of the patients are dropping medication for not being effective or the switching to other medicine or tolerability. Sulfonylurea is offering a balance between the efficacy and side effect and approaching the midline, which is called trade-off line. Sulfonylurea is improving the long-term efficacy up to 52 months in terms of the reducing frequency, nocturia, and urgency, number of beds, and even long-term effect is very high in 60% totally dry and 23 are free of beds. Again, patients who received sulfonylurea, they have a sustained significant reduction in absence from work and the interaction, and 90% of patients are considering the sulfonylurea as tolerable compared to 95% considering it as efficacious medication, as you see here. Now it came one molecule across the globe, And this is, I guess, most of us are using it now, which is beta-3 adrenoreceptor agonist. What is this? Mirabegron is a novel technique which is meeting the unmet need of the antimuscarinic receptor, giving efficacy, high tolerability with less side effect, and optimal balance, and above all, is not affecting our BPH patients. Beta-3 is nearly expressed in 97% of the receptors in the bladder, and this is how the physiology is. This is the urine storage. Usually, sympathetic stimulation is mediated by noradrenaline binding to the beta-3 receptors in the trusor muscle, making relaxation of the muscle. Unlike the voiding, which is stimulated by acetylcholine to the muscarinic receptors. Now, mirabegron is working in the normal pathway of urine storage to activate more the beta-3 and has nothing to do with the voiding. And this is the beauty in this molecule. It augments the bladder relaxation, natural pathway of bladder relaxation without affecting bladder contractility during voiding symptom. That's why it is not contraindicated in patients even with residual urine. And this is a bit mega was the first in its class. And this is the clinical evidence. Here there's the recommendation offering antimuscarinic therapy or mirabegron in adults with LUTS or overactive bladder after failure of conservative therapy. Of course, can be combined with sulfasalazine or alone. Clinical experience summary is fully studied, 41 clinical studies, 29 study phase 1 and 12 phase 2 or 3 studies. And this is the efficacy and tolerability of the molecule. In a study with a primary endpoint studying the efficacy of mirabegron 50 and the 100 compared together, and then comparing the safety and efficacy of the same molecules, and against tolterodine extended release 4 milligram. This is the study design. And here there's a major inclusion criteria having the patient with definition of overactive bladder, micturition more than 8 times per hour per day, or total of more than 3 times episode at night. Excluded from the study stress incontinence, bladder outlet obstruction, risk of retention, polyuria, hypertension. Nearly in each arm, there was 497 placebo, mirabegron 50, 100, and tolterodine 4 milligram. Very interesting that nearly 50% of the patients were switched from antimuscarinic to mirabegron. And here, mirabegron significantly reduced the mean number of micturition per 24 hours from the base to the final visit compared to the other molecules. Again, mirabegron reduced the mean number of urgency episodes from the baseline. Mirabegron significantly reduced the mean number of incontinence episodes per 24 hours from the baseline to the final visit. Mirabegron 50 milligrams significantly reduced the number of nocturia per 24 hours from the baseline to the final visit. Mirabegron significantly improved the mean number of incontinence episodes at each visit, here, and here, up to 12 weeks. Again, reduce the number of micturition at each visit, here, and sustain. Again, decrease the number of urgency episodes from the baseline and starting from 4 weeks. So once you give mirabegron to your patient, you will see the difference, the huge difference is starting from 4 weeks in terms of urgency episode. Number of beds, of course, decreased as early as 4 weeks. Taking all this together will reduce the bothersome symptoms and improve quality of patients. Here, as you see, the highest quality of life. So the conclusion here is mirabegron significantly improved versus placebo, 50 milligram in terms of incontinence episode, and the other in terms of the voided volume and the number of micturition per 24 hours. Side effects are reported, but are not very concerning. There is very low number of patients who stop the medication due to the side effect. In terms of the safety conclusion, overall incidence of side effect is similar to placebo. The incidence of dry mouth is far less than tolterodine. Rate of constipation was similar to placebo, and there is no acute interval or arrhythmia encounter. and it's compared to a placebo in terms of changing the lab finding. So the overall conclusion of this study, mirabegron 50 demonstrate efficacy for the key symptoms of urinary incontinence, frequency, urgency, and the overactive component compared to tolterodine, and again was well tolerated with a high safety profile. Tolerability and safety again was studied. Look here as a dry mouse compared to the other one. Mirabegron is only 2.8% compared to 10% of tolterodine. Constipation was nearly the same as in placebo. Again, long-term effect of the mirabegron regarding the side effect after 24 months is nearly very low compared to tolterodine 4 milligram. There is no change in the pulse rate over time, and there is no change in the hypertension in long term. And again, this is the cardiovascular safety. Safety is only contraindicated in patients with high blood pressure, which is 180 over 110, so 110. There is no Q2 interval. And here there's the time to discontinuation of mirabegron compared to tolterodine. You see the difference between both of them. Having a higher safety and tolerability, the patient continue till the end of the study, and the difference was of high statistical significance. Can be combined with sulfonacin, yes, in symphony, synergy, and even beside study. And if you take it in combination, will it change the number of micturition per 24 hours, and again, the number of maximum voiding volume. Mirabegron as add-on therapy to sulfonacin, here as you see, will reduce the number of incontinence episodes, and will reduce the number of micturition per 24 hours. And this is the bottom line of this. Now, bit-mega alone is indicated in first line of therapy in naive patients, not responding to anticholinergics, and or intolerant to anticholinergics, patient with high anticholinergic load, contraindication to the say anticholinergic or gastric retention, patient with narrow angle glaucoma, CNS disorders, myasthenia gravis, or cholinesterase inhibitors, or patient with high PVR. Now, you can give Omnic plus Visicare if the symptoms are not improving, there is relative symptoms, bit-mega, or you can stay with Visicare only in patients who are controlled with it. There is no other contraindication, and in patients who are having uncontrolled hypertension, arrhythmia, heart failure, or neurogenic bladder. And this is the protocol right now. If you have a patient with irritative symptoms and the BPH patient, start with 5 milligram, if not increase to Visicare 10 milligram. But currently, the first choice is bit-mega 4 to 8 weeks. If there is no improvement, you can step up to bit-mega plus 5 milligram. And again, 4 to 8 weeks, you can jump up to betamigron and bit-mega to Visicare 10 milligram. The last combination therapy is tamsulosin plus PDE5 inhibitors. As you know, PDE5 isoenzyme is very rich in the vasculature of the bladder, urethra, and prostate. And that's this is the guideline here. PDE5 inhibitors can reduce moderate to severe LUTS in men with or without erectile dysfunction. Here, this improvement of Euroflow and tadalafil compared are nearly comparable, and both of them are higher than placebo. The change in the Qmax is better than placebo, and here the change in the IBS score, voiding and total symptoms. This is the urodynamic, very important. After taking tadalafil 5 milligram, bladder outlet obstruction index significantly decreased, and the trousseau activity disappeared in 30% of the patient. Again, 8 systemic reviews using PDE5 inhibitors improve LUTS versus placebo, improve the international index for erectile function, negligible change in the flow rate, but the bold data indicated that 5 milligram can be meaningful to the patient with voiding and nocturnal frequency compared to the other. Combination of PDF with alpha blocker will add to the effect of the urinary symptoms. And again, combination with alpha blocker, there is improvement, and combined therapy is more efficacious than monotherapy, and there is less significant improvement shown in the QMAX. When it comes to hemodynamics, because people are afraid giving the alpha blockers with PDE5 inhibitors, this is the side effects here in terms of the side effect of tadalafil 5 milligram compared to placebo. And again, after this long journey, having high-risk patient from the start, please start combination therapy for day one. And if not, do not take it later than 6 months for the benefit of the patient. At the end of the day, I think tailored or risk-adapted therapy is the key. One size not fitting all. Now you have the clinical best evidence from the literature, combined with your clinical expertise in the clinic, and considering the patient value, you will come up with evidence-based practice offering your patient with optimal decision and optimal outcome. Thank you so much. Any question? Hello?
Professor Anmar Muhammad Habib, Professor of Medical College in Cairo University in Neurology Department in Qasr Al-Aini Department. Professor Anmar, he is one of the pioneers of in holmium laser in Egypt and the Middle East, and he is one of the first to introduce the laser therapy in the Middle East and Egypt. Dr. Anmar, if you are ready, you can start, please.
Good